Yeah,
so let's
great.
start today's CCS. Okay. So you know, as there will be cases. Just 1 second. Hello. Yes. So it's a 24-year-old primary gravida, teacher by profession, who is presenting to the ER at 34 weeks of gestation with severe abdominal pain and generalized swelling all over the body. And there is no significant past medical history. And pregnancy so far was uncomplicated. Her antenatal period on the last visit was 1 month back, documented a blood pressure of 140/90, and fetal edema was there in her ankles. So on arrival in the ER, her blood pressure was 164/110, and initially we evaluated her. We sent blood samples and urine samples and everything, and she was immediately transferred to ICU. After receiving the patient in ICU, she was still complaining of epigastric pain. So when we examined her, we saw that she's slightly tachycardic, and her heart rate is regular, but she's tachycardic. Her blood pressure is quite high, and her respiratory rate is little high. And these are her vitals, and this is her examination. So, what is your? How do you proceed from here, Dr. Marc?
So I think the patient has a so-called preeclampsia because the blood pressure is very high, and she has pitting edema in the ankles.
Yeah. Can you see the case while I'm talking to you?
Yeah, I see the case. Yeah.
Yes, you can see the case. You're good.
Yeah.
Okay. Yeah, continue. Please continue. Yeah.
That is okay, the diagnosis, or do you want more information from me?
Sorry, continue.
Yeah, is the diagnosis for me okay, or do you want more assessment from me, actually?
Yeah, so I'm just asking how do you proceed with this case?
So actually, I want to decrease the blood pressure with antihypertonic medication. What is the different diagnosis? Preeclampsia. Because of the abdominal pain and the epigastric region, it's probably a so-called HELP syndrome. I want to see the liver enzymes.
Okay.
Preeclampsia and HELP syndrome.
Okay. What is your differential diagnosis?
I think the HELP syndrome as a differential diagnosis.
Sorry, come again.
A HELP syndrome.
HELP syndrome. Anything else? Differential diagnosis where we have to give 3-4 diagnoses. So any other diagnosis you have in mind?
It's probably a pheochromocytoma because of the high blood pressure and the tachycardia.
Okay. A pregnant patient with high blood pressure. Anything else is coming in your mind?
No idea. Sorry.
Okay. So actually, the leading things depend on that only. So then what happens is you secure IV access with 2 wide bore cannulas. You start the patient on oxygen and shift the patient to ICU. Then you started the patient on labetalol for the hypertension. After examining her in ICU, she threw generalized tonic-clonic convulsions in front of you. Her blood pressure was 190/120. Investigations from ER has arrived now. So you can see that in their investigations, you can see that the platelets are slightly on the lower side. Patient has mild raised in creatinine. Sodium is slightly low. SGOT is slightly elevated, and PTINR is also slightly elevated. Then you go and contact the obstetrician and ask to do an ultrasound abdomen while she is arriving. You did an ultrasound abdomen. You saw there's minimal ascites, mild pleural effusion, 1 live fetus available. with normal lay-like curve. So what is your diagnosis now?
So because of the seizure, the patient has a eclampsia or HELP syndrome, or
So your differential diagnosis should have included eclampsia in the first minute. That is what I was hinting at, because any hypertensive patient coming to a pre-eclampsia, sorry, hypertensive patient who is coming with high blood, pregnant patient who is coming, the differential should be pre-eclampsia.
because of the first slide, she has no seizure, and actually she has a seizure. She had an eclampsia.
Yes, so preeclampsia is hypertension without seizures. When you have seizures, it is called eclampsia.
Correct. Okay.
So, okay, so yeah, so what is the diagnosis now? It is, you're saying it's eclampsia. So how do you manage this patient?
Because actually I must discontinued the seizure with anticonvulsive medications like diazepam or also benzodiazepine, and probably magnesium. I must secure the airway, decrease the high blood pressure.
Okay, so magnesium, you said magnesium. So what is the dose of magnesium in this patient?
How much magnesium? Or what is your question?
Yeah, dose of magnesium.
The dose, 2 grams, I would give to the patient.
How do you give it? Like loading dose, maintenance dose? What is the regimen?
2 grams in a short infusion over 5-10 minutes.
Okay, and what if another seizures occur after that when the patient is on maintenance therapy of magnesium?
Sorry, the connection was very bad.
Oh, sorry. Okay, so what if there is another seizure while the patient is on magnesium therapy? Like you said, you're giving 2 gram over infusion. So after that, again, the patient is throwing a seizure. So how do you manage the patient?
Like benzodiazepine was an alternative, hypnotics was a general anesthesia. Probably if the seizure was not interrupt. And yeah.
Okay, what do you may monitor while giving magnesium therapy?
I must measure the ECG because magnesium can change the rhythm or can influence the rhythm. I monitored the blood pressure, SO2 saturation, and the blood gases.
Okay. Now the obstetrician decides to do an emergency C-section and transfer the patient to OT, and the baby is delivered. After that, the bleeding has been started, which could not be controlled despite of using oxytocin and misoprostol. So obstetrician actually did hysterectomy and shifted the patient back to ICU on ventilator with fentanyl and NORAD support. In ICU, the blood pressure is really low. So what will you want to do at this point of time?
So the patient not bleeding after the hysterectomy, correct?
The patient was bleeding, that's why hysterectomy was done. But after coming back, now the blood pressure is 80/50. What would you like to do?
So I give volume like balanced infusion. The hemoglobin is actually so.
So blood pressure is 80/50.
No, the hemoglobin. The hemoglobin.
Sorry?
The hemoglobin. How was the hemoglobin?
Yeah. So what you can probably say is I would like to send labs, CBC and all those things to check what is the hemoglobin. I would like to check the coagulation profile. I would like to what you basically do in ICU in a bleeding patient to see what blood products need to be replenished and all those things. I'll arrange for blood products. Yeah, I'll arrange
So
for. Yeah.
the hemoglobin range was in bleeding patients from 8 to 9, more 9, because of the bleeding stop. And I want to give the patient a transfusion with a blood transfusion. Like I must know the hemoglobin, but this was the range for me, 9 gram per deciliter hemoglobin, and I must give the patient blood transfusions, maybe fresh frozen plasma, maybe thrombo concentrate, but the patient's still bleeding. It's the obstetric must stop the bleeding. Like history, Dr. Me was not successful. Otherwise, like a balloon, a tamponade in the uterus, or angiography from the radiologists to stop the bleeding. The assessment was parallel, like for me as a intensivist with transfusions, but the obstetric and the radiologists must also try to stop the bleeding.
Yeah, okay. Any other investigations you would like to send at this point of time?
So the patient was intubated and ventilated. The patient get transfusions. The blood pressure, if the bleeding was still happening, I want to reach permissive hypotension with a mean atrial pressure from 65 millimeters Hg. I must secure the oxygenation. Transfusion with erythrocyte concentrates, and try to normalize the correlation. Can measure a ROTEM, like a rotation thromboelastometry. Can give the patients PPSB or Vipigenin. Yes. What is the actually laboratory? Oh, hello. Hello, can you hear me? Der Marc, hi. Januar, nee, mache ich sofort. Ja.
Sorry, I had interruption. Somebody came to my room. I'm here. Sorry. So we'll go to the next minute. Sorry, somebody's calling me again. 1 second.
Hast du das eingegeben? Ja. T. Ja, genau. Lehre, genau. Cremakos. Genau. Nein, alles klar. Bis gleich. Ja, ciao. Sorry.
Okay, should we continue with the next minute? Sorry, there was some interruption.
Yes, it's okay.
Yeah, so we'll go to the last minute. So the patient's condition is extremely critical, and the husbands and the parents understand unlikely chances of saving patient life. They decided to opt for organ donation if possible for a greater cost, and the social worker informed the organ donation committee, and the process has started. How do you proceed with this case?
In my opinion, it's very early to make such a decision. because I don't know if she has a brain death. I must suggest the prognosis. I must have a CT scan of the brain, in which case the patient is. But in this case, I cannot talk about organ transplantation or anything else. But I don't know if in which status the patient is.
Okay. Fine. So, how do you proceed with organ donation? What is the process of it? What test do you need to confirm organ donation?
Yeah, the diagnosis for the organ transplantation is on the aperture measurement, like CT scan, angiography, EEG, and the clinical measurement, because the patient cannot cough, we have no pupil reflex, the apnea test was negative. And we must have for the brain death a cerebral perfusion arrest. So in this case, I can talk with the husband or anything else about organ transplantation. But this is the minimal diagnostic measurements for organ transplantation.
Okay, okay. So this actually brings us to the end of the CCS1. Now the thing is actually now there are a few lacunas which I felt. One is eclampsia management. I think you have to go and read what is the protocol of eclampsia management, what is the MaxSelf regimen, what to look for in a patient who has been undergoing MaxSelf regimen, what are the side effects of MaxSelf regimen, what is the protocol. So for instance, the dose is the loading dose of 6 grams and then maintenance dose of 2 grams. And if seizure occurs, you have to give another loading dose of 4 grams. So that, and the third seizure, then you have to give another loading dose of 2 grams. So it's a proper algorithm, the Brocard's algorithm, which we use for magnesium sulfate. And the patient has been given magnesium sulfate. You have to look for areflexia, respiratory rate, and sensorium. So these are the things we have to, the deep tendon reflexes are the first thing which actually disappear once you actually give magnesium sulfate. And once you decide to go for brainstem organ donation, you have, the first thing you have to do is apnea test. And after all the prerequisites are met, so you have to talk about these things. What are the prerequisites for declaring somebody brainstem dead? What is apnea test? How is it conducted? So these readings are actually necessary. That is what is the feedback I think I would like to give you in this. Probably. Okay, we'll go to the next minute. So a 23-year-old boy is brought to the ER in semi-conscious state and he's barely arousable to pain. His family gives a history that last few days he preferred to stay alone and was not interested in any regular activities. On arrival, he is arousable to pain. His pupils are bilaterally equal and small. If you see, he is bradycardic, hypotensive. Respiratory system is clear. SpO2 is 96% on room air. Cardiovascular system is normal. CBG is low. So this is the ECG. His last seen well an hour ago and his family denies any symptoms. So what do you think the diagnosis is?
You have a atrioventricular block grade 3.
And how do you manage this patient?
So yeah, I can give you atropine, but it's not a parasympathetic association. I can give him epinephrine with between 10 and 30 micrograms. And if the blood pressure is still decreasing, I can pace him, transcutin. Yeah.
Okay. Okay. Next question. Patient is intubated and put on invasive mechanical ventilation. He is resuscitated with IV fluids and started with adrenaline infusion. His pulse rate is 52, blood pressure is low, respiratory system is clear. His sister arrives soon after 2 empty bottles of metoprolol extended release found. So now we know what it is. So how do you manage this patient? What else will you do in this patient now?
So of the poisoning or the intoxication of metoprolol, yeah, it's possible to dialysis the patient with the metoprolol poisoning. If the blood pressure decreases, the heart frequency is not increases, I can insert temporal pacer over a venous catheter. And if the patient was also desaturate in blood pressure or pulse, I can give him a venoarterial ECMO.
Okay, okay. So what is the drug of choice for beta blocker poisoning?
Once again, please.
What is the drug of choice for beta blocker poisoning?
Choice. Glucagon.
Yeah. What is the dose of glucagon? How does it act?
Oh, I don't know.
Okay. What else? What are the other drugs you give?
Glucagon, epinephrine. Yeah.
What else?
I don't know.
So please go and read beta blocker poisoning because that's very important. So patient is given fluids by atropine, glucagon, vasopressor, and these are the vitals now. So as you can see that blood pressure is still low, heart rate is still low. What will you do now?
Sorry, the RBS is the abbreviation for?
Sorry?
Sorry? The abbreviation RBS is standing for?
I can't understand. RBS, that is the sugar of the patient.
The sugar. Okay. So atropine is not associated in the actually guidelines because it's not a parasympathic effect. Fluids, yeah, possible. Vasopressors, yeah, okay. But I think the pacer is missing in this case.
Yeah.
Yeah.
Okay. So this actually brings to the session end. So again, a few things I would like to tell that beta blocker poisoning, what all medicines we are supposed to give, what is the basic ABCD management of beta blocker poisoning we need to know. Like we have to give insulin infusion, high dose insulin infusion, that is 10 times more than the DKA dose. So because how does insulin act? It actually helps in improving your myocardial contractibility by increasing cyclic AMP mediated all those things. So basically that is very important for to know. And resuscitation of the patient also very important. Glucagon dose, how frequently you have to give glucagon dose, and what are the other role of other medications like lipids and all that also. So please read through beta blocker poisoning as well. For CBS one, 70-year-old gentleman presenting with ascending paralysis, developing after an episode of gastroenteritis. Now he has been referred to critical care for dyspnea and tachypnea. An examination confirms that it's bilateral lower limb and upper limb weakness and diminished reflexes. The CSF analysis shows that cell count is normal, but plasma to glucose ratio is also normal. What data is missing in your lab study in your CSF? What would you expect in this case? And what is your likely diagnosis?
So, old patient with gastroenteritis. It could be Guillain-Barré syndrome. I'm missing blood cultures, the white blood cells. C-reactive protein.
So what is your likely diagnosis?
So it could be a Guillain-Barré syndrome.
Yes. And what indications are there for ICU admission in this patient?
Once again, please.
What are the indications for admission in ICU?
Association with the respiratory system, increasing dyspnea, muscle weakness of the English word missing the swelling. I'm missing the word of English. Sorry.
Okay, we'll go to the next question.
Yeah.
55-year-old male is presenting with septic shock. He's on mechanical ventilation. After initial improvement, he had new onset fever, hypotension, and abdominal pain. CT with contrast revealed this. What is the diagnosis in this patient?
So CT of the abdomen. He have a great bladder of the cholecystitis. A little bit air and bloom of the colon. Yeah, it's a cholecystitis.
What is the diagnosis? Come again?
The infection of the cholecystitis, the bladder under the liver.
Cystitis, you're saying cystitis.
Cholecystitis. Yeah.
There is a 61-year-old patient who is present in ICU with septic shock, and after initial fluid resuscitation, this is the CT. So, what is the diagnosis here?
He have an extra structure of the left kidney, like a cyst.
Yeah. What's your diagnosis? Harmful?
Fluid in the abdomen, free fluid in the abdomen.
Hello? Yeah. So, what is the diagnosis?
A rupture of the left kidney. So kidney fever and.
Okay. Okay, there's a 43-year-old gentleman who is presenting with fever, backache, myalgia, and hypotension. Shortly after arrival, this rash is seen.
She have a tremor of the skin, like the water switch syndrome.
What syndrome? Come again?
Waterhouse Friderichsen.
Okay.
Like a meningococcal sepsis.
What is the cause of it?
Like infection with meningococcus.
Okay. 40-year-old male is presented to ICU with right foot infected ulcer. He is presenting with hypotension, fever, and low urine output. And this is the ABG. So please interpret this ABG.
He has a severe metabolic acidosis, decreased PaCO2 level, decreased chloride level, hyperkalemia, and lactate acidosis.
Okay. What are the causes of metabolic acidosis?
Renal failure, cause of the hyperkalemia or lactate acidosis.
70-year-old man is admitted to ICU with pneumonia. He was on 7 days of antibiotic therapy. He is currently complaining of severe abdominal pain, explosive diarrhea, and abdomen is actually looking like this on right iliac fossa. So what is your interpretation?
The bowel is very distant.
Yes.
It might be caused of the Clostridium difficile infection. Like you get antibiotics before, and it's a megacolon,
Yeah.
a very distant bowel.
Correct. Okay. A 72-year-old gentleman is actually presenting with a history of diabetic neuropathy, CKD, hypotension, and mildly tachypneic. Notice swelling in the right lower limb involving the calf and shin. He complains he has lost sensation on the right side of the foot, not able to pass urine also. Last time he passed urine, it was dark smelling urine. When he came to the ER, they saw that he's tachycardic, hypotensive, tachypneic, saturation is low. The ED technician actually did the ED physician did the bedside ultrasound. He could not delineate structure, he could not see anything. So he stored this. So what is this interpretation?
So you are very fast.
Sorry, you read the, I'll read,
the-
yeah, you will
yeah,
relax and read the question again.
yeah.
Yeah, I've left it for you.
So in the ultrasound, it might be more B lines, like more fluid in the. Can I see the ultrasound picture?
Yeah,
Can you go under?
yes, one second.
So more B lines in the ultrasound. Because you have a swelling of the right leg, might be a thrombosis. His O2 saturation is 92. Tachycardic, it might be a arterial lung embolism.
Okay.
For B lines, more fluid in the lungs.
Okay, next question. A 17-year-old male is actually coming to the this thing post evacuation of the right subdural hematoma after Eve. Sorry, this answer is given. I can't. Sorry, this question actually the answer are given. 1 second. I'll just. I have I think few questions in which the answer is written. I'll have to just erase it. Yeah, now I don't think you can see the answer. So you read this question carefully. 17-year-old male is admitted to the ICU post evacuation of the right subdural hematoma. After 4 days, he starts getting like high grade temperature. You send CSF for culture, and these are the findings of your CSF.
White blood cells are very high.
Yeah, so
Crime
what is your
stain,
diagnosis?
diagnosis. It could be an infection of the brain, like a meningoencephalitis. You have hemorrhagic in the CSF drainage, like a subarachnoid hemorrhage. Yeah.
Now, there is a red flag from the infection control in your hospital. They are saying that there too much of CLABSI is there. So, the number of CLABSI rate is actually increasing. So that is 3, and number of center line places 300. So the CLABSI rate is actually 10, they are saying. So what is your interpretation of this data, and are you really concerned?
My opinion, it's a blood infection because you have a high number in the central line, low number in the. So I don't know.
Mhm. Next question. So 54-year-old man is actually transferred from the ED with progressive neck swelling, and he's not able to put down his saliva. He has his right face and neck swollen. Hoarse voice is there, and he's claustrophobic and blood pressure is low and he's tachycardic also. What will you do for further investigation in this patient?
Can I see the whole text? Is it okay? That your picture is more over?
Yeah. No, there is nothing after this. So.
Okay.
What will you like to do? Can we test?
So we can make fiber optics to the noise and look for the lung structures. Might be a CT scan of the brain and the skull. Yeah.
Next question. A 75-year-old man, is weighing 125 kgs, is coming to the emergency department with fever, and he's drowsy, disoriented also. Now, his serum urea level is actually 50 and creatinine is 2.8. Based on his information, how do you grade the severity of his pneumonia?
Okay, he's drowsy, disorientated, high level of urea, high level of serum creatinine, like acute renal failure.
Yeah.
More
So how do you
information?
grade the severity of pneumonia?
Like the curb 65 score.
Yeah, correct.
Old
What is
man.
65 score?
Age, then the respiratory rate,
Yeah,
the urea,
yeah,
respiratory rate, and blood pressure,
yeah.
and the consciousness. That's it. Yeah.
Okay. So next question, 54-year-old male is presenting with multiple myeloma, high-grade fever. These are his vitals on admission. And these are his investigations. So you can see there is fever, tachycardia, hypotension, tachypnea. He is on day 8 of chemotherapy. His hemoglobin, his neutrophil count, his WBC, platelet count, everything is given. So what is your preliminary diagnosis?
So it might be a pneumonia with a pancytopenia because of the chemotherapy. Like a pneumogenic sepsis with a hemodynamic signs.
Sorry, can you come again? What is his diagnosis, you said?
It's a sepsis, pneumogenic sepsis. Yeah.
Okay. Anything specific about this patient?
Yes, it's pancytopenia because the HB, the white blood cells, and the platelets are very low.
Okay. What will be your preliminary antibiotic of choice?
I give him very wide broad antibiotics like meropenem, caspofungin because of the fungi antifugin therapy. Yeah.
45-year-old gentleman is actually alcoholic and known CLT and cirrhosis. He's a frequent flyer to the hospital with hepatic decompensation. He keeps getting admitted. In this presentation, he's here because he's hypotensive. He's on NORAD support and abdomen is grossly distended. Ascitic tap was done and this was the result. Then his symptoms did not improve on empirical antibiotic and ascitic tap showed polymicrobial growth. So what is your diagnosis? He's not improving on ceftriaxone.
So it could be a spontaneous bacterial infection of the abdomen. And I can give him piperacillin, tazobactam.
Okay. You encountered a patient with gram-negative septicemia and effluent fluid is bluish-green in color due to cholangitis requiring high dose of NORAD support and CRRT, vasopressor, rhinotrope and everything. Based on the above data and finding, the color of urine looks like this. So what is your therapy which the patient was given? So it's a septic shock patient with cholangitis with high NORAD support and his urine became like this.
So it might be a refractory septic shock. I can give him.
Why is the urine color like this? The question is, why is the urine color like this?
It might be that he get a methylene blue.
Yeah, okay. What is the indication of methylene blue?
Refractory septic shock.
Okay, any contraindication of using methylene blue?
I don't know.
Okay. A 60-year-old patient is in date in an ICU diabetic who had a peptic ulcer perforation. He required immediate laparotomy. They repaired it, gave a washout. He was given Piptas for the 4-quadrant peritonitis. He's on TPN through the right IGV. He developed persistent fever, temperature, and sputum culture, and all that showed this result. So, what is your diagnosis here? Sorry, what is your differential diagnosis?
Can I see the vignette once again?
Yeah, this is your case.
Yeah, but your picture is.
There's no picture.
No, your picture. Can you move your picture because I cannot read the whole text?
Okay, okay. This is better.
No, not better. Okay, I try it. Okay. So he's hospitalized 10 days in the ICU to get pip-tats and total parental nutrition. So it's possible that he had a polymicro status, was gram-negative or AMPC bacterials, and I
So
want to
come again.
escalate.
What are you thinking?
It's possible that he have a polymicro status
Microbial?
and she's resistant against piptats. I want to escalate of myoprename covered by
Okay. Okay. You don't want to escalate antibiotics. So there could be some multi-drug resistant organism issue here. That is why you want to escalate the antibiotics to meropenem. Okay. Then, okay. So what is the risk factors of this patient to get a fungal infection?
Once again, please.
What are the risk factors which are present in this patient which can prone him to fungal infection?
Age, ICU during this 10 days. He's have a diabetic mellitus. We have a suppression of the immune system,
Okay.
and he get
Last
pit
question.
cuts for 4 days.
Okay. Last question. 36-year-old male patient is admitted as an IV drug user with infective endocarditis, and his blood culture is negative. So what are the indications of doing an urgent valve repair in this patient, valve repair or replacement in this patient?
An echocardiography is done.
Sorry?
The echocardiography is done.
Yeah.
Also,
That
okay.
only showing vegetations.
It's vegetations.
Yeah.
But he have positive Q criteria, was structure of the valve and the risk from the IV drug abuse.
No, what
So
are the
the question
indications
was,
to do surgery?
that's a structure on the valve.
Structure on the valve.
You said before the ultrasound is done and you have a
Yes.
structure. Yeah.
Yes. So I'm saying, what is the indication to do surgery? Surgery.
Yeah, you have a structure on the valve.
Okay. And what organisms do you suspect if culture is negative in a patient with vegetation?
On the right side, the lung, on the left side, the spleen, the kidney, brain.
What, sorry?
Do you ask me which other organs have
Yes,
a...
which organism do you
Okay.
expect in culture negative?
I cannot see the echocardiography or the ultrasound results, and on the left side, with the aortic or the...
So it is not ultrasound echocardiography you will need. It is microbiology. What bacteria can you think grows in culture negative organisms?
What bacteria?
Yes. What organisms are common in
the following
infective
organ system.
endocarditis when the cultures are negative?
Yeah. On the left side, aortic or the mitral valve, it's the spleen, the kidney, the brain. On the right side, the lung.
Right side it is?
On the right side, the tricuspidal valve, it's the lung.
It's, sorry, no, organism. Can you understand my question?
Yeah. Which organ systems are associated with the
organism, bacteria,
organism. Sorry.
organism.
Okay. Culture is negative. Staphylococcus aureus, Staphylococcus epidermidis, the gram-positive bacteria, and also in the majority the gram-positive organism.
Okay.
Is it the correct answer for you? Or?
Yeah. What is the initial recommended antibiotic regimen?
Once again, please.
What is the initial recommended antibiotic regimen?
For a native endocarditis,
For yeah.
yeah, because not prosthetic valve for anything else. It's fluoxetine, ampicillin, and gentamicin.
Okay. So this brings to the end of the CBS, sorry. Thank you for joining, and you'll have a debriefing on, I think, 18th.
When?
You'll have the debriefing session on 18th.
18. Okay.
Yeah. Okay. Thank you.
Thank you.